it might be acute coronary syndrome, but patient was quite young. Can be pericardial tamponade node, pulmonary embolism. There was possibility of neuromuscular junction weakness, maybe secondary to snake bite or drug induced, but such history was not available with patient, or can be some metabolic cause. The cause related to chest, like uh, tension pneumothorax, was ruled out as HRCT chest was normal. We did ECG, which is suggestive of subtle STT changes with sinus tachycardia. There was no gross STT changes or signs suggestive of ischemia, cardiac ischemia. Her blood reports were suggestive of CBC was within normal limits. TLC were quite on a bit on higher side. LFTs, KFTs were normal, within normal limits. Sugar was normal, and cardiac markers were negative. ABG was done to rule out metabolic causes, which suggested hypoxia with a bit CO2 washout. Rest of it was okay. Bedside 2D echo was done, which was suggestive of enlarged right ventricle with normal ejection fraction, no return wall abnormalities, and no pericardial effusion. D dimer was on higher side, that is 22 microgram per milliliter. Now, with the 2D echo findings, raised D dimer, and excluding other causes, pulmonary embolism was the most likely diagnosis. So injection Clexane was given and CT pulmonary angio was done, which was suggestive of pulmonary embolism. So patient came with the diagnosis with suspicion of COVID-19 and eventually was diagnosed to have pulmonary embolism. We'll discuss about management of pulmonary embolism, but first of all, we'll have a brief discussion about a few theoretical things and recent advances about management of pulmonary embolism. As far as definition is concerned, obstruction of pulmonary artery or one of its branches by material, maybe thrombus, tumor, or fat that originated elsewhere in the body is called pulmonary embolism. Types of pulmonary embolism. Clinically, we divide it into two parts, that is hemodynamically unstable patient, or also called as massive pulmonary embolism patient with or high risk pulmonary embolism. This is defined as one which result in hypotension, that is systolic blood pressure is less than 90, or drop in systolic blood pressure for more than 40 from baseline for more than 15 minutes, or requiring vasopressor and not explained by other causes. Other hemodynamically stable doesn't meet the above criteria. This includes patients who have mild or borderline hypotension that stabilizes with fluid therapy, or have high right ventricular dysfunction. Other ways to classify pulmonary embolism are also there, depending on onset, that is acute, subacute, or chronic. But clinically, they are not of much use as far as treatment of pulmonary embolism is concerned. As far as risk factors are concerned, there might be inherited thrombophilias like factor V Leiden mutation, prothrombin gene mutation, protein C deficiency, protein S deficiency, antithrombin deficiencies, and rare disorders like dysfibrinogenemia. Few acquired disorder or conditions which can lead to pulmonary embolisms are malignancy, presence of central venous catheter, surgery, especially orthopedic surgeries, trauma, pregnancy, oral contraceptive pills, hormone replacement therapy, immobilization, congestive failure, antiphospholipid antibody syndrome, few myeloproliferative disorder, hematological disorder like paroxysmal nocturnal hematuria, inflammatory bowel disease, nephrotic syndrome. All these can precipitate or are risk factor for pulmonary embolism. As far as symptoms are concerned, dyspnea at rest or on exertion is the most common presenting symptom. Patient may have pleuritic pain, cough, orthopnea, wheezing, or less likely, but more present in more severe patient, that is syncope. As far as signs are concerned, tachycardia, tachypnea, on respiratory examination, patient may have cramps or reduced breath sound due to pleural effusion, loud S2, and raised JVP. As we discuss about signs and symptoms, these symptoms and signs are vague or can be associated with other diseases also. So there is no particular sign or particular symptom for pulmonary embolism. So if we suspect pulmonary embolism and patient is not hemodynamically stable, it is very important for us to lead diagnosis of pulmonary embolism as early as possible. For that, we should determine pre-test probability. The pre-test probability of pulmonary embolism is defined by Wells rule. We have different parameters depending on history, hemodynamic status of the patient, and other signs. Wells rule have simplified version and original version. It is always better to go with simplified version. Uh, Parameters are previous DVT, heart rate more than 100 per minute, surgery for or immobilization with past 4 weeks, hemopsis, active cancer, clinical signs of DVT, alternate or uh, um, uh, along with this, if the patient doesn't have any alternative diagnosis, then P is more likely. Every one of these parameter carries 1 mark. If the patient have score of 2 or more than 2, then P is likely, and we should go for investigating with the diagnosis of pulmonary embolism. If the score is 0 or 1, then P is very less likely. Depending after getting a pre-test probability, if the patient is hemodynamically stable, then we should go according to pre-test probability. If the pulmonary embolism is less likely, we should do D-dimer test. If D-dimer is negative, then patient is very less likely to have pulmonary embolism. If D-dimer is positive, we should directly go for CT pulmonary angio. But if the Wells score is more than 2, then pulmonary embolism is very likely, and we should directly go for CT pulmonary angio. If confirmed, then go for treatment. If P is not there and patient is hemodynamically unstable, then we should we should go for other diagnosis and go investigating for them. Lab investigation which are commonly done for pulmonary embolisms are D-dimer. D-dimer is elevated in most of the patients with pulmonary embolism. It have high negative predictive value. That is, it is useful to rule out pulmonary embolism patient with low to intermediate pre-test probability. One thing we should remember, that specificity of D-dimer is suspected in suspected pulmonary embolism decreases steadily with the age to almost 10% in patient above 80 years. It means that if D-dimer is quite on higher side in patient with age more than 50 or more than 60, then we should actually go for other tests rather than relying on D-dimer to diagnose pulmonary embolism. Other causes of raised D-dimer are pregnancy, inflammation, malignancy, trauma, post-surgical treatment, liver disease, and heart disease. So we should remember that if we are suspecting pulmonary embolism in all these conditions, D-dimer should not be relied, and we should go for other investigations like CT pulmonary angiography. CT pulmonary angiography, a quite investigation of choice to diagnose CT pulmonary angiography. Its advantages are it is highly specific for main, lobar, and segmental vessels, and it detects pulmonary embolism rapidly. Diagnose and also help to diagnose other disease entities. And disadvantages are it is not readily available in all centers. It is expensive. It is less sensitive with subsegmental vessel, and it also cannot be used in patient with CKD due to contrast load. These are images of CT pulmonary embolism, CT pulmonary angio showing pulmonary embolism. This is post-contrast image, which the arrow shows that contrast, and the dark area, it is cutoff sign where this area shows pulmonary embolism, the large pulmonary embolism in the proximal pulmonary vessel. Ventilation perfusion scan. it interpret as probability, that is low probability, intermediate probability, or high probability of pulmonary embolism. Diagnosis of pulmonary embolism using VQ scan require integration of the pre-test probability. Normal VQ scan virtually exclude pulmonary embolism. Uh, the it is useful when CT pulmonary angio is contraindicated. That is in patient with pregnancy where CT scan, CT or radiations are contraindicated, or in patient with CKD or kidney disease patient in where we cannot give contrast to patient. These are few images of VQ scan. The right side image show normal scan, and left side image, the white patches are actually nothing but secondary to pulmonary embolism. Echo, bedside echo is one of the good initial screening tests for 2D echo for pulmonary embolism. Few signs are few common signs are right ventricular dilation. It is present in at least 25% of cases of pulmonary embolism. Indistinct regional right ventricular dysfunction with depressed contractibility of RV free wall compared with RV apex, also called Macular sign, is among the specific signs of pulmonary embolism. Uh, pulmonary embolism, uh, uh, and it is seen in all. It is very specific. The specificity varies between 96 to 98%. Increase RV to LV diameter ratio or interventricular septal bulge in left ventricle can also be seen in 2D echo. Cardiac marker, these are not actually useful for diagnosing pulmonary embolism, but these are marker for mortality and morbidity of the patient. As pro-BNP is concerned, it is a marker of right ventricular pressure overload. Its level can reflect the severity of hemodynamic compromise and RV dysfunction in acute pulmonary embolism. Troponin elevated levels indicates that high risk of mortality in the patient. ECG, sinus tachycardia is most common feature on ECG. There may be non-specific STT changes also. Classical findings of pulmonary embolism, that is S1Q3 T3 pattern or RV strain or new incomplete RBP are relatively less common, and they are present in less than 10% of the patient with pulmonary embolism. So as far as ECG is concerned, most consistent finding is sinus tachycardia. Chest X-ray, they are non-specific. The signs or the feature on X-ray varies from normal X-ray. It can present as cardiac enlargement, pleural effusion, elevated hemidiaphragm, pulmonary artery enlargement, atelectasis, and so on. So actually, we cannot rely on X-ray to diagnose pulmonary embolism. Treatment, as far treatment part is concerned, we should first we should assess the severity of the disease. After diagnosing it, then we should give supportive care, including O2 support, proper hydration, maintaining hemodynamic stability. Anticoagulation play important role, reperfusion therapy, and newer therapies like IVC filter should be used. To diagnose or assess the severity of pulmonary embolism, the pulmonary embolism severity index is there, which have various parameters like age, sex, few risk factor like cancer, chronic heart failure, chronic pulmonary diseases, vitals like pulse rate, systolic blood pressure, respiratory rate, temperature, altered mental status, and SpO2 saturation. Depending on pulmonary embolism severity index, we can actually get idea about mortality in the mortality of the just second. We can actually get idea about mortality and morbidity of the patient. Usually class 1 patient, class 2 patient have low mortality risk. Class 3 patient have moderate mortality risk, and class 4 and 5 have high mortality risk. So patient with pulmonary embolism severity index more than class 3, 4 and 5 should be taken care of and should be treated as high risk mortality patients. Initial therapies, respiratory support. We should give respiratory after risk stratification. We should give respiratory support. We should supply. We should give supplementary O2, and target O2 saturation should be more than 90. If the patient has severe hypoxemia, hemodynamic collapse, or respiratory failure, consider intubation and mechanical ventilation without any hesitation. As far as hemodynamic support is concerned, it is based on either IV fluids or inotropic support. IV fluids are first line therapy for hypotension. However, in patient with right ventricular dysfunction, aggressive fluid resuscitation is not beneficial and may be harmful. So as far as pulmonary embolism with hypotension is concerned, appropriate fluid therapy is important rather than adequate fluid therapy. Inotrope should be used if the patient doesn't respond to initial fluid boluses. Anticoagulation we use in acute phase of pulmonary embolism, unfractioned heparin, subacute low molecular heparin, subacute fontoparonox are used. Subacute low molecular heparin and fontoparonox are preferred over unfractioned heparin due to low risk of major bleeding and hit. Unfractioned heparin is recommended only in patients who are receiving thrombolytics, have severe renal dysfunction, or severe obesity. When we use unfractioned heparin, the targeted APTT should be between 1.5 to 2.5 times the normal. This is weight-based heparin therapy with adjacent based on the APTT values. There are various guidelines regarding to this, but we should just remember that initially we should give bolus of 8 units per kg of heparin, followed by 18 unit per kg per hour by infusion for next hour, and we should target the APTT between around 2 to 2.5 times that of the normal values. Other than heparin, enoxaparin is most commonly used drug for anticoagulation in acute phase pulmonary embolism. The doses are 1 milligram per kg in 2 divided doses, or if we have to give it once a day dose, which is relatively less common, then it should be given as 1.5 milligram per kg. There are other drugs which are less commonly used, like dazaparin, dalteparin, natroparin, or fontoparonox. This is for short-term anticoagulation and when the patient is actually admitted in the hospital. For long-time anticoagulation, the duration. See, if the patient have provoked DVT or venous thromboembolism phenomena, then the duration of anticoagulation therapy should be for 3 months, and then anticoagulation should be stopped. If P is unprovoked, then anticoagulation should last for at least 6 months. And few patients like the cases of recurrent DVT or recurrent pulmonary embolism, or patient who have other risk factor like inherited hemophilic disorders can require anticoagulation for lifelong also. Approved drugs for oral anticoagulation or long-term anticoagulation are vitamin K antagonists like warfarin, and newer oral anticoagulations or novel oral anticoagulations like apixaban, dabigatran, and rivaroxaban. As far as warfarin is concerned, it is one of the oldest molecule used for anticoagulation. It is cheapest, most affordable molecule, and most commonly used molecule or drug for anticoagulation as far as India is concerned. But it required dose adjustment, and we should maintain INR between 2 to 3. Daily INR monitoring is required for initial 5 to 7 days after initiation of warfarin. Drawbacks are it have multiple drug interaction, it have high risk of bleeding, and periodic INR monitoring is required. As far as NOACs are concerned, there are various comparative studies between neuro-oral anticoagulation and vitamin K antagonist, like that is warfarin, for the treatment of venous thromboembolism or pulmonary embolism. And all three drugs are proven to be more effective as far as bleeding is as far as compliance to treatment is concerned. It also have decreased bleeding risk. The only few contraindications or drawbacks are we cannot use newer oral anticoagulation when the EGFR or CKD patient with EGFR less than 30, and drugs like rivaroxaban cannot be used. There is uh, moderate to severe liver failures. Reperfusion therapy, they are usually used in patients who are hemodynamically unstable. It includes systemic thrombolysis, endovascular approach, or surgical embolectomy. Uh, Systemic thrombolysis indications are massive pulmonary embolism, that is systolic blood pressure is less than 90 for more than 15 minutes, or the fall in blood pressure is for more than 40 millimeter of mercury than the initial or baseline blood pressure. The controversial indications that totally depend on physicians or intensivists experience. They are severe hypoxemia, large thrombus burden, RV dysfunction, RV dysfunction described by echocardiography or ECG, or RV thrombus or floating thrombus in right ventricle. Thrombolytic agents which are used are urokinase, streptokinase, tenecteplase, or alteplase. All of them are approved for thrombolysis in pulmonary embolism. Dose of urokinase is 4,500 IU per kg in initial 10 minutes, followed by additional 4,500 unit per kg per hour for next 12 hours. STK, the most cost-effective agent, but with high risk. The dose of STK is 2.5 lakhs unit in initial 30 minutes, followed by 1 lakh per unit per hour for next 24 hours. Tenecteplase, I will say, easy to use and more should be used whenever it is affordable, because it is just single dose. Like the dose is 0.5 milligram per kg. Around 30 to 50 milligram bolus dose is given depending upon weight. Alteplase, the dose of alteplase is 100 milligram in 2 hours should be given. Initially 10 milligram should be given as bolus, followed by 50 milligram in first hour, followed by 40 milligram in second hour. Contraindication for thrombolysis are absolute contraindication are intracranial neoplasm, recent surgery, recent head injury, ischemic stroke, history of hemorrhagic stroke, or active or recent bleeding. A related contraindication are hemodynamic instability like raised blood pressure more than 80 of that of systolic blood pressure, history of ischemic stroke, recent internal bleeding, or thrombocytopenia. And there are contraindication for systemic thrombolysis or catheter directed thrombolysis. We should go for catheter directed embolectomy. It is see, catheter directed embolectomy is not available in many centers, but it is one of the most effective and the therapy without any major side effects. It's just like a coronary angiography. Just we take intravascular catheter directed approach. We should go. The interventional radiologist will go till pulmonary vessels and easily thrombosuction or a low dose thrombolysis can be done. It have very less side effect, and the results of these therapies are really rewarding. The only drawback is pulmonary artery perforation can occur during the procedure, which can lead to pericardial tamponade, and it is life threatening, can lead to severe blood loss in form of hemoptysis, but the incidence of this complication are very low. Surgical embolectomy, again, it is indicated when there is contraindication to thrombolysis or there is failed thrombolysis in hemodynamically unstable patient. The drawbacks are same that of the CVT surgeries and anesthesia. If we compare between the different treatment modality for reperfusion therapy, that is those therapies which are actually used in high risk patient and hemodynamically unstable patient. That is thrombolysis, catheter directed fibrinolysis, ultrasonography assisted thrombolysis, and percutaneous thrombectomy. These all can be used, but the in traditional therapies like systemic thrombolysis, the risk like intracranial and major bleed are very common. As far as percutaneous thrombectomy, the it just requires special if it is available, it requires specialties, and other risk of systemic thrombolysis are very less. Just a short discussion about inferior vena cava filters. They are indicated in patients who have absolute contraindication for oral anticoagulants and have recurrent venous thromboembolic episode, including DVT and including pulmonary embolism, despite of continuous anticoagulation. They are placed mainly in infrarenal inferior vena cava. IVC filter can be permanent or non-permanent. Permanent filters are indicated in patients who are have recurrent episode of DVT and pulmonary embolism. Non-permanent catheter can be used during high dose thrombus, initial phases of high dose thrombus burden, or can be used during procedure like thrombolysis for DVT patients. This is the recent guideline of European Society of Cardiology for the treatment of patient with acute pulmonary embolism. Every patient with acute pulmonary embolism should be stabilized first, should be given anticoagulant. If the patient have hemodynamic instability, then we should directly go for reperfusion therapy. Those we have discussed in previous few slides, because delay in reperfusion therapy can actually be life-threatening. If the patient is hemodynamically stable, then we should specify the severity and risk of serious comorbidity and mortality and morbidity in coming future. If patient have good RV dysfunction, less severity, and pulmonary severity index of less than 2, then they are very low risk patient and should be counseled well. Actually, there is no need of hospitalization in such kind of patient. Can be started on oral anticoagulation and discharge and kept with OPD follow-up. But if the patient have high risk of mortality and morbidity, that is PACE score PACE more than class 3 or 4, then they should be hospitalized and should be observed in the hospital. If they deteriorate hemodynamically, then they should be considered for reperfusion therapy. Now let's come back to our case. So we had a 32-year-old male with the pulse rate of 124 with BP 90/60. So he is hemodynamically unstable patient. He was not responding to fluid. His respiratory rate was 30 per minute. SpO2 was 85 on room air. Temperature was normal, and was diagnosed to have pulmonary embolism. So pulmonary embolism severity index was 132. Patient was hemodynamically unstable. So now case of pulmonary embolism with hemodynamic instability with PACE class 5. So what to do next? So definitely, according to guideline, we should go with reperfusion therapy. All options are open, including catheter-directed thrombectomy, systemic thrombolysis, and surgical thrombectomy. But the patient was young and he doesn't have any contraindication for systemic thrombolysis. So thrombolysis was done with tenecteplase. Post thrombolysis, he was improved. His oxygen saturation improved. His O2 requirement reduced. He was discharged home on rivaroxaban after 5 days of hospital stay. He's following up on OPD basis and he's doing well. Second case, a 35-year-old male with no known comorbidities, works in call center. His smoker had left leg swelling from last 15 days. He started cough, right-sided chest pain, that is pleuritic, exertional dyspnea from last 5 days. On examination, pulse was 108 per minute, blood pressure was 110/70 millimeter of mercury, respiratory rate was 24 per minute, saturation was 95 on room air, and temperature was 38 degrees Celsius. On investigations, blood investigations, that is CP, complete blood count, liver function test, kidney function test, and sugars are within normal limit. ECG, chest X-ray was normal. D-dimer was quite on higher side. Left lower limb venous Doppler suggestive of extensive deep vein thrombosis extending from common femoral, deep femoral, popliteal, and distal aspect of deep veins of the leg. CT pulmonary angio was done, which was suggestive of a small segmental emboli on right side. So now we have 32 years old male with hemodynamical stability with PACE score, that is pulmonary embolism severity index of class 1. So it is a case of pulmonary embolism with hemodynamical stability with very low risk of mortality. Then what to do next? Yes, anticoagulation is the treatment of choice. Patient was started on rivaroxaban, counseled well regarding to disease and discharge. He was asymptomatic with respect to pulmonary symptoms after 2 months of follow-up, but leg swelling was still there. His hemophilia profile was done in view of DVT, which was suggestive of factor V Leiden mutation. So he is the candidate who will require lifelong anticoagulation therapy. Hence, anticoagulation was continued. The same patient presented with, which was earlier presented with DVT and previous episode of right segmental pulmonary embolism with factor V Leiden mutation and was on anticoagulation, adequate anticoagulation from last 4 months, came with left segmental pulmonary embolism. Now the embolism is on opposite side. So he was hemodynamically stable and was anticoagulant, but despite of being on adequate anticoagulation, he developed second episode of pulmonary embolism. See, now he develops, he's on anticoagulation, he's hemodynamically stable, so there is no role of reperfusion therapy, but he's developing repeated episodes of pulmonary embolism secondary to DVT. So what to do next? Opinion was taken from interventional radiologist. Patient was advised IVC filter, and he was discharged home with IVC filter and anticoagulation. IVC filters are very important modalities in patient with recurrent pulmonary embolism. See, if we put IVC filter, it is not sure that patient will, there are various conditions like hemophilia syndromes in which patient have tendency to develop recurrent thromboembolic phenomena. A single massive pulmonary episode of pulmonary embolism can be life threatening, but if we put IVC filter, then those life threatening episode can be prevented. So we should categorize patient who are the candidate for IVC filter, and definitely the ideal candidate should be given benefit of IVC filters. Fourth case, it is one of the most interesting and challenging cases of this year for me. It was a 26-year-old female. She was admitted in nursing home. It was her post-op LSCS day 3. The baby was healthy. She was doing well. On day 3, Foley's catheter was removed and she went for washroom. Suddenly, she had episode of blackout and fall while going to the washroom. I got call for the physician opinion. On examination, she was conscious, oriented, but pulse were on higher side. That is 130 per minute. Blood pressure was 86 by 60. Oxygen saturation on 85. On room air, respiratory rate was 36 per minute. Temperature was normal. On examination, air entry, breath sound was reduced on left base. ECG suggestive of sinus tachycardia. Her blood parameters were within normal limits except anemia, that is HB was hemoglobin was 9.3. So we did ECG suggestive of sinus tachycardia. After ruling out all the causes, we shifted her to AIMS hospital for further treatment. Her 2D echo was done suggestive of a dilated RV with no effusion and no other abnormality. D dimer was raised. Uh, uh, but in view of post pregnancy status, we didn't rely much on D-dimer, and CT pulmonary angio was done, which was suggestive of large vase-shaped acute pulmonary thromboembolism at bifurcation of right and left pulmonary arteries, extending into lobar and segmental branches on either side. See, it was massive pulmonary embolism without any known provoking factors. She was started on heparin infusion. Fluid challenge was given. O2 support and other supportive measures were started, and she was put on drops also. But there was no significant improvement in hemodynamical status. So what to do next? Now we have a young female with pulmonary embolism, with hemodynamic instability, with pulmonary embolism severity index class 4, with absolute contraindication for systemic thrombolysis, as she was post of day 3. There was major risk of bleeding if we thrombolize her or if we give her anticoagulation in higher doses. So after discussing with interventional radiologist, cardiologist, critical care unit, option of catheter directed thrombectomy was given to the relatives. Catheter directed thrombectomy was done. Patient hemodynamically improved and her oxygen saturation improved dramatically within few hours of the procedure. These are few images which I got from Dr. Amol Lahoti sir, who is working as interventional radiologist in our hospital. And this case was operated by him only. He done catheter-directed embolectomy in the patient. The initial images shows, it's a CT images shows massive emboli in at the bifurcation of pulmonary trunk. The second image, that is B, showed entering of catheter at the pulmonary trunk. Penumbra machine is there, which is used for thrombosuction, shown in C image. The third image, D. The fifth image explain this is just this I have took from internet. This image actually show the mechanism of thrombosuction, where the catheter is passed from the between the thrombus. Low dose thrombolytics can be used, and it gets sucked in the penumbra machine. With successive aspiration improve in our patient. If we if you see the first image, it was after first suction. The flow in the distal trunk is quite low, and the peripheral flow of the pulmonary vasculature is very small. After second aspiration, the diameter of the pulmonary trunk is improved, and after third aspiration, the flow is almost as normal as before. And after the procedure, her oxygen requirement was decreased to 2 liter, and within 4 to 6 hours, her blood pressure improved and inotoxy were tapered off. She was discharged home after 7 days of hospitalization in hemodynamically stable patient condition with normal without O2 support. She was shifted on oral anticoagulation from day 4 of the procedure. At the time of discharge, her INR with warfarin was 2.2. She is following up on OPD. She has completed 4 months of her anticoagulation, and she is doing well. Take home messages: high suspicion, early diagnosis, and proper treatment with significantly improved mortality and morbidity in patient with pulmonary embolism. Pulmonary embolism response and treatment team, that is PERT team, including physician, intensivist, interventional radiologist, cardiologist, and hematologist, should be formed in tertiary healthcare centers for the treatment of pulmonary patient with diagnosed pulmonary embolism. Catheter-directed embolectomy should be preferred as a reperfusion therapy option in pulmonary embolism with hemodynamically unstable patients. Thank you. These are various cases. We have discussed various scenarios. The same disease, if patient is hemodynamically stable, only anticoagulation will work. If patient is hemodynamically unstable, they have a high risk of mortality and morbidity, so reperfusion therapy should be used. commonly used reperfusion therapy in our setups is systemic thrombolysis, but very rarely or once in a while you will meet a patient who have contraindication for systemic thrombolysis. In such patient, the interventional procedures will actually save someone's lives. Thank you. Gaurav, are you there?
Yes, sir.
I think we should invite Anand Nikalje sir for
yes, like
the session.
Sir, we are indeed honored to have you here.
Yeah,
over here.
am I audible?
Yes, sir. Yes, sir.
Yes, sir. You are perfectly audible.
Yeah, it was a very interesting presentation. Gaurav, you really covered the topic very well. So actually, he included all kind of cases in his presentation. A patient with a hemoglobin stable, unstable, who requires heparin, some patient requires therapy, patient requires liposuction, and patient requires IVC filter. So I think he has covered all kind of management strategies in pulmonary embolism. As he has correctly said, the suspicion of pulmonary embolism is one of the most important thing that we should know. Particularly when patient is having unexplained hypoxemia and unexplained shock, we must rule out pulmonary embolism, though we feel clinically that it is not very high risk for pulmonary embolism. Number one. Number two is basically D-dimer is not very specific marker, and don't believe in D-dimer. Probably in COVID we are doing D-dimer extensively, but the evidence is not in favor of D-dimer, and the dose of heparin probably in patients with COVID with acute respiratory failure for the ventilator requires only a prophylaxis dose of enoxaparin rather than therapeutic dose depending on the D-dimer level. So D-dimer should be taken with a pinch of salt. Only negative value when you have got low clinical suspicion may give you some idea. Otherwise, it has no role. I think CTPA is now available almost in all parts probably, and doing CTPA, and if not possible and patient is critically ill, I think bedside 2D echo with strong clinical suspicion, even you can go ahead with the reperfusion therapy. Am I right, Dr. Gaurav?
Yes, sir. Yes, sir. Definitely, sir.
If you do, yeah. If you have got strong clinical suspicion and patient has got echo evidence of RARV dilatation and failure with a shock, you can even thrombolyze the patient if patient is not in condition to shift for a CTPA. So yes, that sir, is, I think, important part of the treatment. Remember, intervention radiology is additional help to all our intensivists. One more thing I wanted to highlight, that IVC filter is not a routine treatment for a pulmonary embolism. It is recommended for very selected patients where you can't treat with oral or heparin effectively, and there is a risk of repeated thromboembolism, particularly from some pelvic malignancies or lower limb stasis for some reason, and there is high risk of getting DVT, which is going to lead to pulmonary embolism. In that selected patient, you can definitely think of putting a IVC filter. I think we should all know using tenecteplase plays or other thrombolytic therapy. Streptokinase and urokinase, they are cheap, but can be used definitely in case patients who are not affordable. But remember, if you pick up the pulmonary embolism in the right time, I think you will win the battle. So what Gaurav has excellent job. I think picking up in time and giving a proper therapy is definitely reduce the mortality in many of the patients of pulmonary embolism.
Sir, good evening.
At the outset, I really
Dr.
thank
Neeraj here.
Yeah, Neeraj, good evening.
Sir, good evening.
Yes,
sir,
please.
yes, I wanted to ask one question. Pulmonary
Yes.
embolism patient with shock and respiratory distress, tachypnea, and if you are going for intubation, so will you like to start
Okay.
fluid or any vasopressor before, because intubation will lead to hypotension and it can worsen the picture. So
Yes.
before
It is
intubation,
always better to start fluids,
okay.
particularly when you're intubating the patient
Mm-hmm.
and you are giving a vasodilated drugs
Mhm.
like midazolam,
Yes, sir.
lorazepam, propofol, and
Mhm.
even a muscle relaxant. They
Muscle
all
relaxant.
will cause vasodilatation and
Vasodilatation.
drop in blood pressure. And
Mhm.
positive pressure ventilation is again going
Yes.
to cause drop in your venous return. So
Mhm.
fluid is important at
Okay.
the time of intubation and
Okay.
probably using sedation.
Sedation. Yes, sir. Okay, sir. Yes. Thank you.
And if required, you
Mhm.
can start vasopressor therapy like
Okay.
noradrenaline for
Noradrenaline.
time being, and then you
Mhm.
titrate it depending on the response of the patient.
Yes, sir. Okay, sir. Thank you, sir. Yes.
Anybody would like to comment about the pulmonary embolism and the cases presented by Dr. Gaurav? I think a lot of senior people are attending the webinar. Dr. Lakkas is here, Dr. Rushikesh Dixit, Dr. Kavra madam from Jalna. They are also joined with us. You're all welcome for any comment or any question. I think we must all thank Poland team for making this activity as a routine activity per month. And I encourage, I think everybody can come forward like Dr. Gaurav, who came forward and he presented a very good lecture on pulmonary embolism with the background of his practical cases. So we are all having some cases, interesting cases, and going back to books and reading the newer guidelines and newer strategies is always enrich us in further management of the patient. So it is not activity of one or two person. Anybody can actually contribute in keeping this ball moving ahead. So thank you, Poland, and again thank Gaurav for an excellent presentation.
Thank you, sir. Thank you.
Thank you,
It's
sir.
an honor to have both of you over here on this platform and forum. And I'm sure that these insights will indeed keep on enlightening the practices of critical care. So thanks both of you for your insights. I request participants to come forward and ask their doubts or queries if there are any.
If there are no questions, before concluding the session, I'm just wanted to invite you for two interesting activities we are holding on. One is Dr. Iyer's lecture on the tips of preventing ventilator-induced lung injury tonight at 8 o'clock in MGM Hospital. So if you are in Aurangabad and you have a time, I think you must come for a lecture by a very eminent speaker, Dr. Iyer from Pune. And tomorrow we are having a open session where doctors and common people are also going to come to listen about the concept of end of life care or comfort care by again Dr. Iyer in presence of High Court Justice Mr. Varale. So these two activities are actually very interesting. So today evening at 8 p.m. MGM and tomorrow at 10 a.m. Sunday morning again in MGM Devtan Hall. So see you soon, and we'll continue this case presentation. I'm actually thinking to present a case next time about the snake bite. I'm getting a lot of patients of vascular snake bite. and I think almost everybody is actually having a good number of experience of managing vascular snake bite. So let us have a good discussion next month. Thank you very much.
Thank you, sir.
Yes. Once again, thanks to both of you, sir, and all the participants present over here. So I'm sure this we will continue throwing the lights on different topics of critical care, scenario. So until next time, from Poland Healthcare and entire team, signing off. Take care, guys.
Thank you.
Thank you.